Hello all, I'm Dr. Neema Bhatt, Senior Consultant Hematologist, Hemato-Oncologist, Transplant Physician and Pediatric Oncologist. I work as a Senior Consultant at Apollo Hospitals, Bangalore. Today we'll talk about a very relevant and important topic called thalassemia. So thalassemia is a blood disorder where patients are usually inheriting the disease from one of their parents or usually both of their parents, where the parents are thalassemia trait. What thalassemia means is they are able to produce red blood cells, which is a type of blood cells which helps us deliver oxygen to the rest of our body. However, the production is abnormal. So it is called, it comes under an umbrella of diagnosis called hemoglobinopathies. So what happens in these patients is right after the age of around 3 to 6 months, they will have very low hemoglobin, ranging anywhere between 5 to 6, when the normal hemoglobin should be around 12 to 13. These patients require lifelong blood transfusions. If they do not receive blood transfusions on a regular basis, once every 2 weeks to 3 weeks or maybe up to a month, they are not able to maintain hemoglobin of anywhere between even 8 to 9. So for the normal development of a child, normal hemoglobin should be approximately around 9 to 10 grams per deciliter. Ideal normal hemoglobin should be around 12 grams per deciliter. But in a thalassemia child, if you leave them without any transfusions, their hemoglobin fails to go beyond 5. And this is an important implication or complication of the disease. What happens? Some parents might think we'll just give them blood the rest of their life. What is the final treatment or what is the need for a complete cure? So what happens when we give blood to any patient or any individual is blood comes with iron. So there is a lot of iron that goes into the body, and iron is a heavy metal that tends to deposit in the heart, it can deposit in the brain, it can deposit in the liver and cause long-term implications including liver failure or heart failure. To prevent this, what we have to do is try to cure the thalassemia, which means the children should be able to go off of blood transfusion, regular blood transfusions. How do we do this? So there is a procedure or a highly skilled procedure called bone marrow transplantation, where we first conduct what is called HLA typing for different family members along with the patient. So if we find a match with one of the family members, we take the bone marrow of that particular person after testing that they don't have thalassemia major, and then we put the patient through this procedure called bone marrow transplantation. Is it a simple procedure where it can be done on an OPD basis? Not really. Bone marrow transplantation is less of a surgery, it's more of a meditative procedure is what I like to call it, because it requires a lot of pre-screening. It requires the patient to undergo a lot of screening to make sure that they're ready to tolerate the procedure and they will actually come out with good outcomes. It requires the donors to undergo sufficient screening, because otherwise we may not be able to use them as the BMT donors. And it requires a series of planning by delivery of medications, by delivery of stem cells that are collected from the donors, and then monitoring the patient on a regular basis to make sure that the bone marrow donor or donation that's been given, or the stem cell donation that's been given, is actually working and helping the patient maintain normal hemoglobin counts. Thalassemia and bone marrow transplantation dates back to as long as 25 to 30 years of age. But in the past, we did not have great outcomes because we did not have the medical facilities that we have available today. High resolution HLA typing, it starts from as basic as testing, making sure that we are testing for the right infections like CMV and getting the reports back in time, testing for post-transplant markers like chimerism. So all these parameters have significantly improved, especially in India, over the last 5 years. And these parameters is what has improved our outcomes, which used to be as dismal as only about 50 to 60%, now to as good as 85 to 90%. A thalassemia patient, if they have a fully matched family donor, can have an outcome as good as 90 to 95% if managed and treated the right way. If they do not have a full match or a 100% match, then we are able to do transplants with a 50% match donor, which is usually one of the parents or a sibling, and in which case the outcomes are slightly lower but still quite comparable at around 80% to 85%. What bone marrow transplant does for thalassemia patients is it cures them of a lifelong chronic illness that keeps the patient bound to a hospital. It also brings down the constant ongoing cost of medical care, which is a huge relief of cost burden on the healthcare system in general as well as the patient. These patients also require iron medications to maintain their iron at a good level. Post-transplantation, they're able to come off the iron medication. So it takes off a lot of burden for the patient, the caregivers, and the healthcare system. So BMT for thalassemia should be a non-negotiable way of treating thalassemias and should be the standard of care for cure of thalassemia. If you have any questions regarding thalassemia and bone marrow transplants, please reach out to us at Apollo Hospitals, Bangalore.